call CT scan. It matters, okay? There's a big difference. Doctors cannot predict how long someone will live. It's very unfortunate when I get asked that question when I see the patient for the first time in the ER. They have a feeling that something's bad, something's going on, and they say, well, you know, if this is something bad, how long will my mother or my father live? It's impossible to predict right now. It just depends on so many things. There's so many contributing factors, and we'll go over that as well. Plastic stents are what we place in the biliary tract. Remember I talked about those? Those can get blocked. We'll talk about that, why that's important as well in a little bit. If someone has a metal stent placed in that canal, that doesn't mean that you can't have surgery if you have any type of biliary cancer or pancreatic cancer, but we usually clinically, the application of it, the books say one thing. What we do in real life, if you get a metal stent, if someone says we had to place a metal stent, it's usually not good. We sometimes call that, I'm sorry to say this, but it's called a stent to grave type of a situation, because the likelihood of that being taken care of is not going to happen. So it's more to make the patient comfortable. So pancreatic cancer is a systemic disease. Surgery is rarely the optimal first treatment. Rarely optimal first treatment. So the first thing people want is, well, let's take care of it. Can't you take it out? No, that's not the case, because there's other things that have to be done. So it's a team sport. It's a team disease that has to be addressed aggressively, multidisciplinary with different teams. What does that mean? I just said CT scan, interventional gastroenterology, that's my team. We're way up here because we are usually the team that diagnoses it. So when someone goes in with this pain, they usually look very jaundiced, very yellow. How many of you have seen someone that's jaundiced? It's really interesting because I'll ask my patient, so when did you start turning yellow? I don't know. My neighbor just told me that I look yellow and I didn't realize it. Or I don't know, my son that visits me on the weekends noticed the color and told me to get it checked out. If you look at a tinge, I used to say the video Thriller, Michael Jackson, yellow eyes. I usually say that because everybody knows what that means. If you see someone changing a tint of color, a little bit of yellowness in their eyes or a tint in their skin that they look a little yellow, don't ignore it. It could be liver disease, but it could also be, it could be liver disease, but it could also be something that we need to be concerned about. We go inside and take samples from that tree that I showed you earlier, or if there's a mass on the pancreas that's visible on CT scan, diagnostic imaging, we go in there and we take a sample of that tissue and we send it off to be analyzed. That's how we usually are able to make the diagnosis. From there, medical teams, surgical teams, and radiation oncology teams try to get the patient to chemotherapy, radiation, and we call that neoadjuvant therapy, meaning that we want to shrink the size of the tumor before someone decides to go in and try to resect it, to give the patient the best possibility to do well. We manage them inpatient and then outpatient. It just goes from there. So a CT scan with the tumor looks just like this. So here you have the liver that's on the side, you have some bowel, the two kidneys, our spine, and this is what it would look like on CT scan to us. Now, like I mentioned, yes, the options are surgery, but chemotherapy combined with radiation, chemotherapy alone can be done as well, but we want to do everything in conjunction. Who is this gentleman, Mr. Alan Whipple? How many people know who he was? Cool. In 1935 to 1940, Dr. Alan Whipple came up with this awesome idea to do a pancreatic duodenectomy. And what we do there is we take out the common bile duct. Remember the picture I showed you at first? Mm-hmm. We resect the common bile duct here, part of the pancreas, and the duodenum. And that's the Whipple in a nutshell. So it looks like this afterwards. Okay, that's the one I was going to try to skip. So, sorry. The natural history of pancreatic cancer has to do with what stage it is, and that's not my area, so I won't try to speak on something that I'm not extremely well versed in. This is oncology, but they stage it. Stage 1 and 2 is potentially resectable. These are the months from diagnosis that the patient will survive on this side. Stage 3 is locally advanced, and stage 4 is metastatic. I'm happy to say that I would say half of the patients that I see on a daily basis are resectable, and half of them are not. But it's here the months look a little bit more not as convincing, but if someone is resectable and they're stage 1, as you can see, it's the highest opportunity to live up to 2 years. What do you think will make this person resectable if we do what? If we diagnose the patient early?
Yes.
Yes, and we don't just ignore it and send it by the wayside, okay? So talking about resection, so when someone presents, they usually present with this color on their skin and their eyes. They are obstructed. There's a semi on the freeway and traffic cannot get through. We do a CT scan like I mentioned to you earlier. They usually have a pancreatic head mass or something's going on. And then they try to diagnose it and stage it. We call it staging in different levels so we can decide what to do with the patient. This is us right here. This is what we do all day, every day. EUS, FNA, ERCP with stent. There are about, I don't know, maybe 3 or 4 doctors in Fresno that do this. If not, you have to go to Stanford, UCLA, or San Francisco. I am very blessed to work with a doctor that I have worked with for 10 years now, and he is the best at what he does. And I'm very fortunate to work with him, Dr. Chowdhury. This is what he does every day, EUS with FNA. So EUS is endoscopic ultrasound. So when a woman is pregnant, they do ultrasound on the outside, right? So what we do as advanced endoscopists, we look with an ultrasound on the inside of the body. So the camera goes inside the body, and on the tip of it is like an ultrasound that we would do on the outside on a pregnant female. We look on the inside, and the images that come up on the screen show us exactly what he can see and see if there's a mass. And at that point, the patient is completely asleep under general anesthesia. We can put a needle through that area, take cells out, and we have a pathologist right there in the room looking at it under the microscope. We're doing that today, in fact. And they tell us if the cells that we got are adequate to make a diagnosis. So that's exactly what we do all day is that, oh, that was really fast. Sorry, I apologize for that. I pushed the wrong button. That was the next one. So, patients with early treatment of micrometastatic disease are 80 to 90% of resectable patients. I like this word. I love this word. I'm falling in love with this word today. Micrometastatic disease, meaning it's so itty-bitty that it can likely be addressed. Nevertheless, metastatic is a concern, but there's some hope there. Patients with rapidly progressive disease will not be subjected to surgery. Why? Because the aggressiveness of the disease won't allow us to go in and subject the patient to a major surgery. That Whipple is a major surgery. You saw many organs being addressed and resected. It's not a little appendectomy or a little gallbladder surgery. That's a major surgery. As well, I've seen patients that are young in their, I don't know, 58, 60, that are not in good condition to have a Whipple. They have heart disease, they have diabetes, they have COPD, they have other issues. And I've seen patients that are 75 that are in great condition and they do have a Whipple. So the age to me is not a big factor as much as the overall health of the individual when we make these types of decisions. Now, how do we know whether the patient is resectable or not, or operable or not? We take into consideration, this is, to me, it's like a little cartoon that's very easy to understand. So you have the pancreas here, this is tumor. You see that it's not invading what we call, let's just call this a vessel, and let's just call this an artery, the superior mesenteric vessel and the superior mesenteric artery. These are just channels of blood that carry blood throughout our body. You see how here they're not touching? Do you see that? They're not touching, correct? Mm-hmm. This person is likely resectable because it hasn't invaded the blood system. The blood goes through everywhere. When you hear of lymph node involvement or metastasis, there's likelihood of this type of involvement. Borderline resectable, do you see how now it's touching it, barely kissing it there? That's where big concerns come in. Maybe this person would be better with neoadjuvant therapy, chemo and radiation, right, to shrink the tumor. But here, do you see the difference between this slide and this slide? Mm-hmm. This is not very helpful to be resected, not very good. High likelihood of morbidity, mortality because of the advancement of the disease. This is advanced. So that's how we look at it in a simplistic view, if you will. A lot more goes into that. This is just the definition of that as well. These are CT scans that show exactly what I did, but in a CT scan. I want to scroll fastly to this. We are very, I want to let everyone know here, we don't live in Los Angeles, San Francisco, New York, or Chicago, where big, huge clinics, or even near Stanford. Disadvantages of the neoadjuvant approach. Well, guess what? Here in Fresno, you are we all are very blessed that when I read this, I said, disadvantage of neoadjuvant approach. I said to myself, tissue diagnosis required EUSFNA. We do 5, 6, 7, 8 of these a day here. So in this valley, we do have very talented physicians that can get tissue diagnosis for patients. So that's a blessing. If someone lives very far from these big medical centers, it is a challenge. We get people at our hospital that are transferred from, you can name any city in this valley that I get a phone call at 1, 2, 3 o'clock in the morning, and can they transfer the patient to us for an EUSFNA? And I decide whether we can accept the patient or not, and I decide when. If they say it's a Friday, say we can't take this patient until Tuesday or Wednesday, I know our schedule and I know when we can take this patient to do this very important EUSFNA. Without this, we can't diagnose. The other problem is biliary decompression, meaning when you have a tumor, the tumor is pressing upon the canal. It's pushing on it from all sides, and it may be causing so much pain and so many symptoms of the patient that they'll turn super yellow. They may get septic and actually get very sick with infection because nothing's processing, nothing's going through. So physicians do have to work together. We try our best, but there's this many patients and there's this many of us. But we are blessed here in the valley to have very, very good advanced endoscopists that do this. So we are very blessed to have them here. These are just studies that would take me, I would say, about 2 hours to go over. But extrahepatic obstruction of the bile duct